Kneeling down. Think about squatting for a second. What other joints are you clearing with a squat too? Knee. That's why I like a squat, because squat, number one, I'm going to see how well that person wants to load that hip, but I'm also getting a good idea on those knees too, and ankles probably, right? So that's a good test. What does single leg stance tell us?
Balance.
Balance on one side, and your book talks about a stork standing test, where we put them here, and now we bring the leg up a little bit more, and all this does, it really kind of throws your center of mass off a little bit more. So you can look at those there. Going up and down stairs, how about that? Yeah. It's a nice test, okay, especially for folks who are a little bit older, and you're going to look now, because now what has to happen, now they have to stand on that leg and elevate up. So you're asking for a little more muscular coordination. Is running a good thing to do? Depends who it is. Depends who it is. If someone tells you it's that running athlete that we just talked about before, but they don't have signs of femoral neck stress fracture. Let's say they have signs of IT band syndrome. It's after I run a few miles. Do you think watching their running mechanics would be important? Yeah, especially after they fatigue a little bit. So you may have to keep them on the treadmill for 15, 20 minutes and see if their gait deviates a bit, because otherwise you may not know what to treat. And then how about hopping? Hopping is something, if you don't have a treadmill and you can't assess running, we give you a couple different ways to assess hopping there. And in your clinics, we don't have it here, but you could put a piece of tape down here, and you could lay a tape measure down, stand on one leg, hop out as far as you can. Now, for your femoral neck stress fracture patient, is this something that you want to do?
No.
Probably not. Probably not. And we're going to talk about it a little bit, that some people do assess this. We just want to see if you can even stand on one leg. Can you even have the ability to even do anything at all? They just can't even get off that leg one bit. Okay, so there's different ways, and just know there's different ways to measure that. So you can look at how far they can hop out, just go as far as you can, looking at the distance of maybe 3 hops. We could ask them to hop a certain distance, say 20 feet, as fast as you can. We can time it, and then we could also have them maybe hop across a line. So we have a line here. I'm going to ask you to hop out that side, and this side, 3 hops. Let's see how far you go and compare it one side to the other. If you decide to start hopping, do you know what's normal? Good side versus bad side. How far should the good side be in comparison to the bad side? Or the bad side be in comparison to the good side? Do you know? 85% is a fair number. 85 to 90%. Now you have to ask yourself, as a high-level athlete, if they can only give me 85% of that good leg, is that enough for them to get back to doing whatever it is they need to do? What do you think? Hard to say, isn't it? If it's a running athlete, I don't really care how much they can hop, okay, because they're not doing that. It's kind of an explosive activity. What if it's a rugby player or a football player or a basketball player playing at a high level? They could be at risk for further injury, couldn't they? If they're lacking 15 or 20% on that involved side, maybe we want to get them up a little bit higher. So just something to think about, but we say in there 85%, less than 85% symmetry, we start to get concerned about that. How about posture? Where are you going to look at your patient from what different angles? Anteriorly, laterally, and posteriorly. Perfect. So you get front, back, and from the side. And what are we looking for?
Symmetry.
Asymmetry.
Yeah, we're looking for symmetry. And one thing we're going to look at, and we might as well go ahead and cover this now, the palpation scheme for the hip has a couple different landmarks associated with it that are at the pelvis, okay? The skeleton. So someone come up and point out where the iliac crests are on the skeleton. Where are the iliac crests? Trendelenburg, by the way, skeleton. Where's the iliac crest? Good. The iliac crests are here. How about the ASIS? You know? Good. So the ASIS is here. And how about the PSIS?
Back body.
Yep. So right back here. So can you come up for a second? So just go ahead. I'm just going to have you just elevate your shirt up a little bit. So you can palpate these landmarks right at this point while they're standing there. That's So iliac crest, you ask them to put weight equally on both sides. Just go take your shirt off. You don't. And so equal distribution of weight on both sides, but now you're assessing posture. Go ahead and face the group. If I want to assess the iliac crest height, I'm just going to put my hands just gently up over top, and my hand should be about level. Okay? So the rest of the folks can see it. So we're going to get to this anyway, but this is not a bad time to do this. And Sergeant Zedek and I talked about, for the practical exam, we're going to tell you how we think you should probably palpate these landmarks in what position. And I think standing is a fair position to put these people in to palpate iliac crest, PSIS, and ASIS. Do we say any other ones, or was that it? Just those three.
They can do greater stroke also,
Greater
but
stroke can. That's right. That's right. So there would be the other one. I just want to make sure. But I want to make sure that you understand why we're doing this. Bottom of page 81, why are we looking at ASIS, iliac crest, and PSIS? What are we looking for?
Symmetry.
Those three landmarks. Level. We're looking for symmetries, okay? So if they're off a little bit as I go on the iliac crest, I'm concerned about that. We're going to go down to the PSIS. So you just got to lower down a little bit. There's a couple of little dimples right down here. You want to just put your fingers up under those. We're looking to see is it level. Okay? Looking for the PSIS. Now you got to remember where it is in the skeleton. Right there. PSIS. Okay? ASIS, go ahead and turn around and face me. All right, so you're just going to lower down just a tad just to get your fingers on the ASIS. Right there. I'm looking to see, are my thumbs level? Okay? Face through. Right here. So these are three landmarks that you can get while they're in standing while you're doing your postural screen. Okay? And let the patient know while you're doing it. Go ahead and face that one more time. And then greater trochanters, where are those? Right here. So you just got to kind of feel up, and you'll feel soft tissue above it. And for me, just kind of go in. I'm looking for that shelf right there, a little shelf right there over top. So step back and see if those look level. Okay. You got to kind of look back a little bit so you can kind of get an idea. So iliac crest height, PSIS, greater trochanters, and then have the patient flip around at ASIS. So that's part of, in my opinion, that's part of your postural screen. You do those right in standing. What do you guys think about those? You okay with that? And so when you assess your patient, we're going to let you go ahead and do that. So understand that for posture, I think the expectation would be to assess those landmarks right at that point. Okay? The other thing with observation that we have in there for you guys is this concept of skin color, erythema, ecchymosis, effusion, and edema. Let's define those terms. Erythema, what's that? Redness. Okay, ecchymosis?
Bruising.
Bruising. Now, can you tell the difference between ecchymosis and erythema?
Yes.
Yes.
Yeah, bruising is bruising. You know, we'll put the ones up in the clinical screen again, but you know, the area is kind of bluish, purplish. As it gets later in the phase, it starts to get a little greenish, right?
Yeah.
Yellowish, right? As the blood's kind of getting taken out of there, cleaned up. And what's redness?
It's just red.
Redness is redness, right? I mean, go, smack your forearm and you can see that erythema. So that's erythema. What are we thinking erythema might mean? Inflammation. I agree. I think erythema means inflammation. What does ecchymosis mean? Bruising, and there's probably trauma at that point. What are your other two terms? Effusion. What's effusion?
Swelling up.
It's swelling on the joint.
Swelling at a joint, and edema. Swelling. And then atrophy. What's that mean?
Weakness.
Muscles are getting smaller. Okay, so we're looking at those different components when we're doing our observation. And we're going to tell you guys, if you see redness or erythema, right, you're going to want to put your hand on there too to figure out what. Is it warm as well? Is there a temperature change? And I think the back of your hand probably works best for that. The back of your hand probably works best. So you're going to want to do that as well. And then bottom of page 82, clearing joints. This is all observation. Lots of information there, isn't there? I think this is really the really key component of the exam. This is stuff that no one else is doing. How am I going to clear the lumbar spine? Flexion. Extension. What else?
Lateral side bending.
Side bending. Patient is that. What am I looking for when I go through those? Because we talked about this clearing a joint. What am I looking for?
Rolling out.
I'm looking for substitution, but when I'm asking them, what am I really trying to figure out? Patient, you told me your pain is in the right anterior aspect of your hip. So when we start to move, well, that hurts a little bit. What are you going to want to know? Where? It could just be his back. Well, do you have back problems? I do, actually. But you just told me, when I screened my special question, you told me you didn't have back problems. You're going to get into that kind of nonsense? If you're frustrated that day, maybe you will. But, you know, this is like a relationship at this point, right? It can start out really. Have you ever been on a bad first date? It never goes to the second one. It's that kind of stuff. So, look. He has back pain. Big deal. Deal with it. That's something else you may need to deal with. But what are we really looking for? Am I recreating your symptoms with these movements?
Yes.
That's what I want to know. Okay, a little bit of back pain, that's fine. You start moving people around, you're going to find all kinds of stuff. Right? Flexion, extension, side bending to both directions. What other joint do we have to screen out? Knee. So would you mind coming up here? So the knee, how are we going to screen the knee? Flexion, extension. With a little bit of head down. With a little bit of overpressure. Would I check both sides? Why would I check both sides? To know what normal is. So this is his good side. So I flexed up, a little bit of overpressure, gentle, right? Come here, extension, a little bit of overpressure into extension. Any problems with that? I'll say no. Now I'm going over to the injured side. Remember, he has a hip problem, so I'm going to be careful with how far I flex him up. I'm going to flex his knee. I get 10 range. What do I want to know at this point? Because he might have pain with this. What do I want to know? Where? Oh, I have pain down here. Now, if he says he has pain up here and that's his primary of his symptoms, am I going to be concerned about that? This could potentially be a factor in this, right? So that's why we're screening the joint. We're looking for a recreation of his symptoms. And then I extend. Now, if he's going through those kind of gyrations, and this stuff happens, if he's starting to go through that, you got to try and figure out, am I moving the hip or is it his knee? Okay, you may need to palpate a little bit more, that type of thing. But normally, you're going to get a normal knee exam. Okay, and I've already told you that those slip capital femoral epiphysis, how do sometimes those kids present? Do you remember that? Knee pain. So they're going to have a complaint of primary knee pain. You're going to assess their knee, and what are you going to get? Normal knee exam. It's not until you start to flex their hip that recreates their knee pain now. So it can go both ways. So that's how you screen the knee. Thank you again. We're almost done. You guys are going to get to start working together again. But that observation, I think, is extremely important. And then after that, what we'll have you do is, since you guys are experts already, we're going to have you go ahead, do your observation. So you're going to do your gait, posture analysis, screen out the back, screen the knee. When they're in standing, what else are you going to assess? 4 landmarks. Good. And if you want to know where those are located, the palpation scheme is on page 88 and 89. So those 4 landmarks are on page 88 and 89. We're going to screen those in standing. Okay. What else are you going to assess for? One last thing. Symmetry, but those 4 things, kind of the bad stuff. You're looking for what? Fusion, edema, erythema, bruising, ecchymosis, atrophy. Good. We're looking for that. All right? You guys ready? Okay, so let's go back to the first patient. So whoever the first patient was, they were that osteoarthritis patient. Go ahead and pair up. Go through your observation. Go ahead. Does anybody have any questions on the range of motion or manual muscle testing? We have the expert in the room. Range of motion and manual muscle testing. How do you guys feel about this? Any questions? Hang on before you get started. Any questions on range of motion and manual muscle testing?